Hello everyone. Regards from the Indian Journal of Anaesthesia. I, Dr. Shayak Roy, is going to present a systematic review and meta-analysis titled Effect of Intraoperative Fluid Volume on Postoperative Pulmonary Complications in Thoracic Surgeries, authored by Dr. Shreya Adhikari, Dr. Nitin Gupta, Dr. Mukund Gupta, Dr. Savan K. Nagesh, Dr. Souvik Chaudhuri, Dr. Rakesh Garg. The authors are from the Department of Anesthesiology, Infectious Disease and Critical Care Medicine, Kasturba Medical College, Department of Community Medicine and Family Medicine, AIIMS Jodhpur, Rajasthan, and Department of Onco-Anesthesia and Palliative Medicine, AIIMS New Delhi. Postoperative pulmonary complications such as respiratory failure, ARDS, acute lung injury, prolonged air leak, pneumonia, and pleural effusion occur in 12 to 40% of the patients post-lung surgery. Mortality rates exceed 50%, increasing proportionally with the number of PPCs per patient. Reducing intraoperative fluid administration decreases hydrostatic pressure in pulmonary capillaries, potentially reducing PPCs. Excessive fluid administration may flood the lungs, stress the myocardium. Early study findings indicate that large perioperative fluid loads contribute significantly to pulmonary edema in pneumonectomy cases. But there is lack of clear recommendations. Evidence on intraoperative fluid management in thoracic surgeries is conflicting. Some studies advocate restrictive fluid strategies, others do not find a significant impact. So the research questions following the PICO framework were as follows. In patients undergoing thoracic surgery, is the amount of intravenous fluid significantly different between those who developed PPC and those who did not? In patients undergoing thoracic surgery, does restricted fluid administration compared to liberal fluid administration reduce postoperative pulmonary complication? The primary outcome measure was the amount of intraoperative fluid infused, and the secondary outcome was postoperative complications in adult patients undergoing thoracic surgery under general anesthesia. This systematic review and meta-analysis is conducted according to the PRISMA guidelines. Before initiating the systematic review, this protocol was registered with Prospero with the following ID and date. In patients undergoing thoracic surgery, studies comparing PPCs in restrictive versus liberal fluid therapy, or the studies comparing average intravenous fluid infused in those who developed PPCs versus those who did not, were included. Those studies where mean along with standard deviation or median via interquartile range were not provided, and restrictive or liberal strategies were not defined clearly, were excluded. Case studies, case series, conference abstract, and letters to the editor were excluded. All articles published till 31st August 2024 in PubMed and Embase were screened. Articles published in all languages were included. All comparative studies were included. The following search string was used with and or Boolean operators. Further studies were selected by manually researching the references identified from the original studies. Duplication removal was done using Ryan software. And after duplication removal, the studies were selected in two phases. First, title and abstract screening, followed by full text screening. An Excel sheet was used to record the extracted data. The following variables were collected as in author's details, type of study, total number of patients, definition of restricted and liberal fluid strategies, number of patients with postoperative complications in restrictive and liberal strategies, and mean fluid infused in those who developed complication and those who did not. The Joanna Briggs Institute checklist for analytical cross-sectional studies was used to assess the quality of the included studies. Publication bias was addressed with funnel plot. For those studies where mean fluid infused was compared between PPC and no PPC, PPC was considered as the primary outcome, with fluid infused considered as the exposure. For those studies where incidence of PPC was measured between restricted and liberal fluid, the liberal fluid strategy was considered as the exposure, with PPC considered as the secondary outcome. Wherever more than two groups of the fluid strategies were present, the lowest volume was taken as the restrictive, and the remaining groups were compiled into one group of liberal strategies. The total fluid intake used for defining the strategy and the mean or standard deviation of the total fluid infused was expressed in ml per kg per hour. Whenever the value was unavailable, the study population's mean operating time and the average weight were converted into the desired unit. The pooled mean difference in intraoperative fluid infused was calculated using a random effect model via inverse variance method. The pooled proportion of the PPC in restricted and liberal intraoperative fluid arms were compared using a random effects model via Mantel and Henschiel method to calculate the pooled risk ratio. The results were represented by a point estimate with a 95% confidence interval. The heterogeneity across the studies for all the outcomes were tested using tau square, chi-square, and I-square test. An I-square of more than 60% was taken as significant heterogeneity. Review manager was used for the meta-analysis. Trial sequence analysis was conducted for the primary outcomes to evaluate the cumulative evidence and adequacy of the recruited sample size using the TSA program. The cumulative sequential Z-score curve was constructed by calculating Z statistics from each study. In the results, after proper screening and exclusion, total 11 new studies were included in the review as seen in this Prisma flowchart. While comparing the baseline characteristic in these 11 included studies, we can see that 9 studies were conducted after the year 2010. Most common indication for the surgery were malignancy, followed by idiopathic pulmonary fibrosis. Lobectomy was the most common type of surgery, followed by pneumonectomy. Both VATS and open methods were taken into consideration. 4 studies included the neoadjuvant chemotherapy and radiotherapy. In 25% to 100% of the patients, thoracic epidural were considered, and 7% to 93% of the patients were of ASA physical status more than or equal to 3. In these 11 studies, we can see that the major postoperative pulmonary complications were pneumonia, ranging from 4.2% to 41.2%, followed by acute lung injury, ARDS, atelectasis, bronchopleural fistula, respiratory failure, pulmonary edema, and exacerbation of IPF. While comparing the mean intravenous fluid between those who developed PPC and those who did not, in the 6 studies, we can see that in the PPC group, the incidence ranged from 2.8% to 54.7%, with the mean fluid infusion ranging from 6.58 to 11.1% ml per kg per hour. Whereas in those group where no PPC was seen, the mean fluid was infused from 4.61 to 11.2 ml per kg per hour. And in the remaining 5 studies, where comparison was done in the liberal versus restrictive fluid group, the definition of the restrictive fluid infusion were taken as less than 6 to less than 16.8 ml per kg per hour. Whereas the liberal fluid group, the definition was more than equal to 6 to more than equal to 16.8 ml per kg per hour. In the restrictive fluid group, we can see that the PPC percentage is ranging from 6.1% to 43.9% of the cases. And in the liberal fluid group, we can see that from the 10% up to 36.75% of the cases, patients develop PPCs. While analyzing the forest plot in the first 6 studies between the PPC and the no PPC, we can see that the mean difference of the IV fluid were 1.51 ml per kg per hour, which is significant, the p-value of 0.001 with I-square of 56%. But in the remaining 5 studies, while comparing the restrictive and the liberal group, we can see that the risk ratio is 0.58, but the p-value is not significant, and there is increased heterogeneity of 91%. Total 21.33% of the patients developed PPCs in these included 11 studies. Smoking, physical status, neoadjuvant therapy, diabetes, and pre-existing respiratory diseases had an impact on PPC incidence. In a study by Kaufman et al., the PPC group had more elderly and undernourished patients. Parquin et al. Revealed that the preoperative radiotherapy and chemotherapy also affected the incidence of PPCs. Blank et al. Noted that the PPCs were higher in surgeries for the malignant than benign conditions. Study by Kim et al. PPCs were lower in VATS than in open thoracotomy technique. Acute lung injury occurred more frequently after pneumonectomy than lobectomy or lesser resections. In this study, both analyses were too few to perform any subgroup analysis or create a funnel plot to look for publication bias. The fluid administered varied significantly between the studies. Study by Elam et al. Showed that the odds of primary lung injury increased by a factor of 1.2 for each additional 500 ml of perioperative fluid administered. But in contrast, we have found in the study by Yu et al. That the risk of postoperative pneumonia increased with restrictive practices. But it must be noted that this was a retrospective study and the difference was not significant. The limitation of this study was all the studies were observational and had biases inherent to the study design. There was high methodological and statistical heterogeneity. Most studies did not uniformly record fluid strategies. Definitions of restrictive and liberal strategies varied across studies. The strength of the study were this is the first study to address this question systematically. This study reviewed 3 databases comprehensively to screen the published literature to date. Critical appraisal of the included study is done. 2 different meta-analyses were done to pool all the relevant data. And TSA was applied to demonstrate the completeness of the current systematic review and meta-analysis. So in conclusion, we can say that the mean intraoperative fluid in those who developed PPC was significantly higher. A trend was noted towards higher PPC in those who received liberal intraoperative fluids compared to the restrictive strategy. TSA showed that the cumulative Z score crossed both the required sample size and the line of benefit, indicating that no further studies are required to be added to the meta-analysis. So a restrictive fluid strategy might be beneficial in preventing PPCs. Thank you.